But it is my great pleasure to introduce Dr. Astrid Pujari, who is board certified both in integrative medicine as well as in internal medicine. I was very fortunate early when I came to Virginia Mason to work with her in the internal medicine department. She is currently the medical director for integrative medicine here at Virginia Mason. And she did have private practice for over 13 years, where she combined both Western or traditional, natural, and mind-body medicine. She speaks nationally on multiple topics and has also led several trips to India for some of her work. She has written an integrative health column. She is also the author of 2 books on integrative medicine focus, both for the Healthy Knee and the Healthy Back book. She is a wealth of information, and I'm so pleased that she is here to give us the talk on evidence-based supplements for respiratory infections. Thank you, Dr. Pujari.
Thank you, Carrie. So it's such a pleasure to be here today. Thank you so much for joining, even virtually. So today we're going to be going through evidence-based review of supplements for respiratory infections. And the reason is because I'm sure, like many of you, I've gotten so many questions around all these people who are taking different supplements for trying to prevent COVID, or worried about that, asking me a lot of questions about that, both from physicians and from patients. And also, a number of patients, which again, I'm sure you've seen, are getting misinformation on the web. And so I just wanted to go through the data with you so that you can be in a position to better share with your patients about what you feel like the data reflects. Of course, I'm going to be saying something that's obvious to many of you, but COVID is so new, there's really not studies directly on that. So the focus today will be on data regarding respiratory infections in general, rather than on COVID specifically. Although, as I've mentioned, a lot of patients extrapolate that data to then talk about COVID. So I will do my best to try to interface with that. Also, I want to share that some of the studies do mostly have children, but the focus today is really for adults. So I'm an internist by training, and I just want to be clear that the focus today is for adults. Okay, so let's start with vitamin C. I'm sure many of you have heard questions from patients about vitamin C. So vitamin C is a water-soluble vitamin, and it's very important for normal immune function. That's why patients are using it right now. I get a tremendous, practically everybody I've been seeing is using vitamin C to prevent COVID. And just as background, the vitamin C levels in white blood cells are about 100 times higher than they are in the serum, because white blood cells use a lot of vitamin C. Actually, it's very important for lymphocytic activity, phagocytic activity, leukocyte activity. It's anti-inflammatory. And as some of you may know, and I'll go into this in a minute, there's been interest in using IV vitamin C as a treatment for the acute respiratory distress syndrome with COVID. The idea behind that is that IV vitamin C, there's a study that suggests that it might decrease the cytokine surge in early sepsis. So that's the rationale behind that, and I'll go through some of the data around that in a minute. So we're just going to go through a lot of studies because I want to help you with that education for your patients. So in terms of oral vitamin C, there's a study from 1994, it's a systematic review of 21 randomized control trials. There was no change in the incidence of cold when using vitamin C for prevention. But acutely, it did decrease the severity of symptoms and duration of episodes by about 23%. However, there was inconsistent quality in those studies. This study, when I reviewed so many studies in preparation for this lecture, and the one I've selected, because as we know, a systematic review or meta-analysis really is only as good as the quality of the trials in there. So I do try to pull out individual studies to go through as well. This is one of the better ones from 1999. It was a randomized controlled trial of 715 students, so this is a younger population. And what they did is they actually used vitamin C acutely. You'll see it's in a fairly high dose there at 1,000 milligrams every hour for 6 hours and then 3 times a day. And there was an 85% drop in symptoms, again, acutely. And this is important because I see a lot of patients, they're mostly using it as prevention rather than acute treatment. This was a study from the Cochrane database of systematic reviews in 2013, a meta-analysis of 29 randomized control trials with quite a few patients, 11,000 patients. And what you can see here is that actually vitamin C was useful in elite athletes like marathon runners, etc., for acute treatment, but for the general population, again, vitamin C was not helpful for prevention. In terms of acute treatment, again, the duration of colds in adults dropped by about 8%, and in children it dropped by about 14%. The severity also improved based on this study. Now I want to go through IV vitamin C. There is a study from the Journal of Intensive Care from the year 2020 that was a meta-analysis of 687 mechanically ventilated patients. And basically this is an important point, is that they only use vitamin C. It wasn't combined with hydrocortisone or other stuff because that's a different question altogether. So they used, as you can see here, 1 to 6 grams of vitamin C per day, and if they were ventilated, it decreased the average ventilation time by about 25%. The caveats when I reviewed this study is that they included a wide variety of situations, so burns, a lot of the patients there were cardiac patients, sepsis, so I'm not sure how really well this actually applies to patients who were hospitalized with COVID on mechanical ventilation. This is actually, again, another study of just vitamin C from 2019, IV vitamin C. So again, it was a multi-center, double-blind, randomized control trial of 167 patients, and this actually, the patients did have sepsis with ARDS, so that might be a little more relevant. Their symptoms were only 24 hours in duration or less. And they got 50 milligrams per kilogram every 6 hours versus placebo for a total of 96 hours IV. And you can see it made no difference in the primary outcomes of drop in CRP and organ failure scores, but I found this change in secondary outcomes to be pretty interesting. Mortality dropped by 46.3% in the placebo group, or excuse me, mortality was 46.3% in placebo versus 28.8 in the vitamin C group. ICU free days, which again seems clinically relevant to me, dropped from 10.7 to 7.7 with the, it dropped by about 3 days. And they transferred out of the ICU earlier. To me, that's clinically significant. Of course, that study needs to be replicated. There is a study actually currently underway in China and I put the actual reference here, that they're going to be studying it for basically for COVID right now. 12 grams IV vitamin C BID times 7 days versus placebo. And I just want to mention that there are 2 other studies. I did review them, but because of this question about whether or not hydrocortisone is really relevant or not with COVID patients who are hospitalized, I think that's a whole different question that is really better discussed in another type of lecture. So, okay, so dosing. Basically, as I've mentioned, a lot of patients are using vitamin C for prevention, but the data doesn't really support it for prevention, at least for colds. And that's really where the data is. So acutely, you can use 2 to 3 grams per day orally, and as I mentioned in this one study, they actually used a fairly high dose of 6 grams for a day and then 3 grams per day after that for 5 days. I put the IV vitamin C dose that was used both in the JAMA study as well as going to be studied in China right now. For side effects, with oral vitamin C above 2 grams per day, you start to get an increase in nausea, diarrhea, and actually sometimes, just as my clinical experience, sometimes I see urinary irritation as well, in addition to heartburn. It can precipitate kidney stones, so actually vitamin C gets metabolized into oxalate, and so it can increase not only calcium oxalate stones, but also uric acid stones because it changes the pH of the urine. And then with IV vitamin C, and this comes up, because in integrative medicine we have a lot of patients who do IV vitamin C for other reasons. So with cancer patients, for example, there's theoretical risk that it may increase clots. G6PD, you really do need to check for G6PD before administering IV vitamin C because it can cause hemolysis in high dose. And there is this issue of a false read, and I think this is clinically relevant for diabetics, particularly on IV vitamin C on the glucometer. But there is this case report that I found interesting. Actually, at 10 grams per day orally, it did change the readings on the glucometer. Okay, moving on to zinc. The reason there's a picture of oysters here is because zinc is high in oysters. So zinc is important for immune function. It's also important for wound healing and resistance to infection. Zinc actually inhibits the replication of a SARS coronavirus in vitro, and there's the study there. This is from 2010, as you can see. Zinc is very important for a number of different enzymes in the body, including reproduction, growth, development, thyroid, etc. Interestingly, with zinc deficiency, it's one of the only vitamins that when you don't get it when you're growing as a child, it actually creates an issue where you just don't grow to as big a stature simply from the zinc deficiency. That's how important it is for the body. So it's found in meat, seafood, dairy, legumes, nuts, and seeds as well. Phytates, which are a component in plants and also in grains, actually bind zinc, so make it less absorbable. And that is relevant because in vegetarians, then people can develop a zinc deficiency. So zinc deficiency actually is fairly common in the elderly, particularly in the nursing home, but also in the elderly in general. And this is important. We'll get to some studies on this later. As I mentioned, if somebody's vegetarian, it's something to think about. And also remember, of course, that medications can deplete different vitamins. So ACE inhibitors, ARBs, thiazide diuretics, which, we use these all the time for hypertension, and acid blockers. I know we always think about acid blockers and B12, but it's also good to remember that it doesn't just affect B12 and calcium, it also affects zinc. And medical issues like diarrhea can deplete zinc. The adult RDA is 11 milligrams per day. And these are just pictures of foods that are high in zinc. Okay, so let's go through zinc for treating upper respiratory infections. This is a study from the Annals of Internal Medicine. It was a double-blind randomized control trial of 100 employees at the Cleveland Clinic, and they basically treated them within 24 hours for a URI, and they used a zinc gluconate lozenge, and 13.3 milligrams every 2 hours versus a placebo. And the patients who used the zinc did have a shorter duration of symptoms, about 40%. Another study from 1992, double-blind randomized control trial of 73 young adults. They had a shortened duration again with the lozenge of 50% versus placebo. And then this last study from 1987, this was actually people who were experimentally inoculated with rhinovirus, which is again our number one cause of URI. And zinc lozenges actually did drop the duration of the respiratory illness by 4.5 days. So it decreased the likelihood of infection and shortened duration of symptoms. For the elderly, I know that a lot of people have been concerned about their loved ones who are in nursing homes or older loved ones. And so I just wanted to go through again, as we just mentioned, zinc tends to be low in the elderly, very common in general for a lot of reasons. You know, if the teeth aren't working well, it's hard to chew meat. It's just, there's a lot of different pieces there. So in 2010, there was this study of 578 patients, and you can see it's in quite a few nursing homes, 33 nursing homes, and they basically, what they did is they measured zinc levels and they just stratified them into two groups. Either they were low or they were high. I mean, we should say low or normal. And those who had a normal zinc level, okay, 50% lower antibiotic use, and a lower incidence and shorter duration of pneumonia in general. And I think this is important, is that the all-cause mortality was 39% lower in these patients. So that seems clinically relevant to me as well. The Annals of Nutrition and Metabolism in 1997, this is another study, double-blind randomized controlled trial of 81 elderly patients, again in a nursing home, for 2 years over time. So this is a long study, which is nice to see. And they had quite a few groups here. So it was placebo versus basically a mineral group that includes selenium and zinc versus a vitamin group that had, you know, vitamin C, beta-carotene, alpha tocopherol, which is basically vitamin E, versus a combination of everything. So it's 4 groups. But basically, the patients who, first of all, one important point, and this is maybe not directly relevant, but again points out the very high likelihood of nutritional deficiencies in our elderly patients. 75% of these patients were low in so many of these vitamins. And so zinc, the patients who received the zinc actually had less infectious events over 2 years, and the other groups really it didn't impact in terms of infectious events. So in terms of dose, again, zinc probably is more useful, again, because I see a lot of people who are using zinc sort of preventatively, but really preventatively it's probably more relevant in a patient who is deficient, which is why I went through, again, what the population is that tends to be deficient. And for that, zinc gluconate, 20 milligrams per day is usually plenty. For acute, however, it may be beneficial. Now, because of zinc, and it needs to be ionized actually, in terms of absorbability, I would recommend either a zinc gluconate or a zinc acetate lozenge and not other types, because they may not be actually as easily assimilated. And in the studies, they've used 9 to 24 milligrams every 2 hours during symptoms for 4 days. You can see that then that's going to exceed our upper limit. Our normal upper limit of zinc is 40 milligrams per day. So temporarily you're going above that upper limit if you're doing that, and it should not be continued long term. So 4 or 5 days is enough, but I wouldn't continue that long term because you can develop a copper deficiency with all the resultant issues with that. So hemolytic anemia, etc. I absolutely do not recommend a zinc nasal spray. I know I have some patients who've done that. It can cause anosmia where people lose their ability to smell. The other thing about a lozenge that we need to keep in mind is that people sometimes really don't like the taste, or it'll cause nausea. Okay, so the bottom line, just as a review, for vitamin C, acutely it might benefit. Vitamin C the data isn't really supporting prevention at this time, except for in extreme athletes. And for zinc, again, acutely it may benefit. For elderly, it might benefit actually for prevention, especially in patients who are deficient. But for both of these, you're really going to want to start as soon as possible. So the moment somebody has any symptoms at all, you want to start. Okay, elderberry. This is one of my favorite plants, actually. So I put a lot of pictures of it, and I put it on the front. So the elderberry pictures you see here, the black one and then the white flowers, are actually the one that is medicinally relevant. It's Sambucus nigra. And that tends to grow in Europe or on the East Coast in the U.S. The red one you can see over here on the other side is actually our native Pacific Northwest elderberry, which is it's Sambucus racemosa, which is beautiful. I have it growing in my yard right now, but it's really not relevant from a clinical standpoint. So we're really going to focus on Sambucus nigra. The berries, by the way, always have to be cooked because otherwise they're not good for you. Okay, so elderberry, in terms of the mechanism of action, it has been shown to kill several different strains of influenza. I remember doing a talk a number of years ago when swine flu was out, and I was talking about elderberry for swine flu because there's all that concern about running out of the vaccine and what could we do, et cetera, et cetera. I've had a physician ask me about the concern regarding increasing cytokines. In fact, I think I had a patient ask me that as well. And that's based on this study here in the European Cytokine Network in 2001. That's the study that suggested elderberry might increase cytokines. But I want to point out that there's also a study that suggested decreased cytokines, which people may be less familiar with. But the thing about a plant that I just want to point out is a plant is a very complex combination of chemicals. Actually, elderberry specifically is very high in something called anthocyanins, which are very potent anti-inflammatory, antioxidant, and quench free radicals. So when we're thinking about SARS, et cetera, and cytokines, there's a lot, actually elderberry, when we used to use this thing called ORAC, which is a laboratory measure for antioxidant value in different foods. And so the higher the ORAC, the more antioxidant a food is. If you compare, say, cultivated blueberries, which are, let's say, I'm going to say this offhand, might be about 600 ORAC. Elderberry is 14,000 ORAC for a cup of the same berries. So just to point out that there's a huge amount of antioxidant value in elderberry, which likely actually quenches free radicals. And so we have to keep in mind that plants are complex. And that one study really isn't enough to help, discern a question like that. So in terms of acute respiratory illness, this study from 1995 was a double-blind randomized control trial of 27 children and adults with the flu. And they basically used a specific product called Sambucol, which actually has had a lot of studies on it, well, relatively speaking, for a supplement. It decreased symptoms, using it acutely decreased symptoms, as you can see here, by 91%, including fever. And symptoms resolved quicker, so 2 days versus 6 days. And they measured that including fever, muscle aches, all the different symptoms. In 2004, this was a double-blind randomized control trial of 63 adults with the flu. And they used, again, an elderberry syrup, which is similar to Sambucol, for 4 days versus placebo. And there was a drop in duration of symptoms by 56% versus placebo, and they used less rescue medication. Okay. Now, this study is from 2015, double-blind randomized controlled multi-center trial of 473 patients where they combined it actually with a treatment, more of a Western medical treatment versus a particular, again, it's a liquid drink called Echinacea Force hot drink. And they did that for 10 days versus 5 days. For the medication, there was similar efficacy for both, but they didn't actually have a placebo. So this is both, they're both active interventions. The study in 2009 listed here is a double-blind randomized controlled trial of 64 adults with the flu, and they received 175 milligrams of elderberry. This was actually in the form of a lozenge versus placebo. And there was a drop in a number of different symptoms, including fever, headache, muscle aches, etc. And at 2 days, 28% had complete resolution of symptoms with the elderberry versus 0 in the placebo. Last study, I think this is sort of partially relevant with COVID, maybe not, is plane flights, which we're not really flying too much right now. But this was a double-blind randomized control trial actually of 312 adults in Australia. And what they did is they started taking a capsule of elderberry 8 days prior to the flight. They continued it. They were actually on a very long international flight, and I forget how long that flight was, but it was very long, from Australia. So they started 8 days prior, and then they did 900 milligrams during and for 5 days after the flight. And it didn't actually prevent colds, but what it did is if somebody got a URI, it dropped the severity of that URI by 58%, and it dropped the duration by 2 days. This is another picture of black elderberry here. Okay, so the dose. There's a range in product quality, actually, and Consumer Lab is a resource I highly recommend for looking at quality of supplements. They're an independent testing group. And the Sambucol, interestingly, that I spoke of many years ago in this other talk and is actually no longer available. So the one that is now available is called Sambucol Black Elderberry Syrup, and it's not exactly the same as what was studied before, but presumably it's close. And it's 1 tablespoon 4 times per day that's used at the onset of symptoms. Another one that had a very good review in Consumer Lab was this capsule. So for those of you who are interested potentially in flying in the future, Elderberry Force met the USP standards and actually had what it said it did in it at 335 milligrams per capsule. And that's easy to find in health food stores or online. You really want to start, again, similar to vitamin C and zinc, you really want to start as soon as possible. You, again, don't consume raw berries, for those of you who have, like me, elderberry growing in your yard. And rarely it can cause diarrhea or nausea, but that's pretty rare. I've recommended it to a lot of patients. And it can, the elderberry flower, sometimes people are allergic to that, so it's good to keep in mind. But usually in the syrups, they're not necessarily including that. Okay, probiotics. Probiotics are another question I've gotten a lot of questions about. They are living organisms that provide benefit to the host, and for respiratory infections, the main probiotics that have been studied are lactobacillus and bifidobacteria. The idea here is that they block pathogenic organisms from binding to the intestine and growing, and they modulate nonspecific cellular and humoral immunity. They actually, interestingly, secrete chemicals, and you can see them listed here, including hydrogen peroxide to kill other bugs. And I found this interesting. There's a study of L. plantarum, which is a form of lactobacillus, that they actually gave to mice, and it decreased the replication of the H1N1 influenza virus and dropped the amount of virus that was in the lungs and increased survival. This is, of course, a mouse study. So, and then in this other study on Shirota type of lactobacillus, which we'll go through, there's some studies on that actually in humans, actually was antiviral against a coronavirus that causes GI symptoms. So it's a different kind of coronavirus, but called TGEV. And I put the reference there for your information. In fact, actually, I just want to say I actually listed all the references in detail at the end of this talk. So if you want to refer to any of the data that's presented here, you're welcome to. So for prevention of respiratory infections, there's a study from 2015, meta-analysis of 12 randomized controlled trials with approximately 3,500 patients. And it dropped the number of acute respiratory symptoms, dropped duration, and people had less antibiotic use. Also, another older Cochrane database of the same question, it decreased the odds of 3 or more respiratory infections by 43% if you used probiotics. Now, this is preventatively. So, again, prevention of respiratory infections. A lot of these studies here are going to be in kids, because kids, obviously in daycares and in schools, get exposed to a lot of infections and are frequently getting sick. So they had a study here of kids, 571 healthy kids in a daycare, actually, and they used Culturelle, which is a very specific form of lactobacillus, versus placebo, and they saw a 16% drop in the incidence of respiratory infections, 17% drop of complicated upper respiratory infections and lower respiratory infections, and a 19% drop in the need for antibiotics. These are further studies on prevention for respiratory infections. So in Pediatrics 2009, they did a double-blind randomized control trial of 80 school children. So you can see the ages here. And it dropped fever, cough, and rhinorrhea by 45%, shorter duration of symptoms, and less school absences. And this study by the European Journal of Nutrition in 2017, This is a randomized control trial of older patients, 96 male workers at they were actually in an organization that was providing this. So they used the Shirota fermented milk. It's basically a form of lactobacillus is a very specific type versus placebo, and they did this for 12 weeks. And those people, the men who were doing that, dropped the incidence of respiratory infections. So you can see here by 26.3%, shortened the duration of symptoms by 2.2 days. The dose. Actually, interestingly, I have a lot of people ask me about dose of probiotics. You don't need a lot for it to work for respiratory infections. For other things, because probiotics, there's a huge range of things you can use probiotics for. But for respiratory infections, you really only need 1 to 5 billions per day for URI prevention. And the side effects, it's very well tolerated in general. Sometimes when people are starting, they'll get some gas and bloating for the first few days. Quality of a probiotic really matters. And here's examples of probiotics that have been used in the studies that I just quoted that you can look for because they are, they've actually had the studies on them. Okay, the bottom line for elderberry and probiotics, basically elderberry acutely, it may benefit prevention, may benefit in terms of plane flight to decrease symptoms if they actually develop. But again, you're going to need to use it right away. For probiotics, it actually may benefit for both acute and prevention. And it seems, again, the other thing we need to keep in mind with supplements is there's the data on efficacy, but there's also just evaluating, well, what's the risk? And honestly, the risk is fairly low for all of these products, depending, of course, on their medical background. Echinacea. This is got ranked as one of the top plants to plant in your garden by Better Homes and Gardens, actually. It grows nicely. It's actually a native to the United States, and there's a lot of species that we have here. Actually, the native peoples used Echinacea as a treatment for infections as well, and they would even use it as a poultice. So in vitro, Echinacea kills enveloped viruses, including coronavirus, influenza virus, and it modulates, again, nonspecific immunity, and it is also anti-inflammatory. These are studies, I'll just summarize really these studies by saying, to be honest, when I review these studies, and I have in detail, they're really very mixed quality, so it's difficult. There's a really big variety in their dose, big variety in the quality of the product used, the product type, the schedule that they use. So it's really hard, even though I'm putting these meta-analyses here. The issue with these meta-analyses is that, again, the quality of a meta-analysis is only as good as the studies in it and the synergy of those studies. So even though we're seeing here some drop in incidence by 45%, decrease in odds by 58%, 10 to 20% for prevention, the study quality, I have to say, is pretty mixed, in my opinion. This actually was a study, again, trying to look at then, all right, can we look at a better quality double-blind randomized control trial rather than a meta-analysis? And here we have one of 755 patients. This is actually probably one of the best studies I've seen on Echinacea so far. They basically use Echinaforce, 0.9 mLs TID versus placebo for 4 months as a preventative. And they saw a drop in the number of colds by 59% and duration of cold symptoms by 26%. There are several studies on experimentally induced cold, and they prevented cold in 2 out of the 3 studies again, but the sample size was really small and it didn't reach significance. So again, we're back to this issue around study quality. So then when I go back to, well, what's the safety? Because again, if someone's using it, there's also assessing safety. And to be honest, Echinacea is really pretty safe. It's well tolerated. Theoretically, you should not use it, actually, if you have an autoimmune disease. And it could, because it's in the daisy family, so somebody who has an allergy might develop an allergy to it. If out of all the reviews, I would probably say that this product that I just reviewed, the Echinaforce, by this company. The reason is because it was in this study here. So quality matters with herbs, and so that's why I put it up there, is because it actually has a study on it, and a fairly, one of the better studies. So in that study, as I mentioned, it was used for prevention, but not really for treatment. Vitamin D. Again, I got a number of questions about vitamin D. We generally think about vitamin D, as we all know, for many other things, including bone health, but right now it seems to be a popular topic for respiratory illness. It's a fat-soluble vitamin that actually also acts like a hormone. And I just want to remind us all that food is really not a very good source of vitamin D. Even milk, I've had people ask me, does milk have a lot of D? You would have to drink a quart of milk a day to even get close to it would be very difficult to achieve, let's put it that way. The idea behind using vitamin D for respiratory concerns is that higher levels, now remember this is an observational study, so it doesn't prove cause and effect, but higher levels correlate with better pulmonary function and FEV1, and there's thought that it might decrease immune-mediated inflammation of the airway. So let's look at some studies on vitamin D here. There was a meta-analysis in the British Medical Journal of 25 randomized control trials with 11,000 patients approximately, and it reduced the odds of acute respiratory tract infections in all patients by about 12% versus placebo. What they noticed, interestingly, is I know for patients in nursing homes, sometimes we use once a month dosing or even once every 3-month dosing, but actually what they found is for respiratory infections, it's better if you use it daily or even weekly rather than doing this once a month dosing. The greatest effect was in those patients who are the most deficient. So again, remember our elderly patients, people who don't go outside, they're going to be more likely to be deficient. Also in Seattle, our latitude is such that it's quite hard to get vitamin D conversion, especially in the winter months, so that's something else to keep in mind. In 2010, there was a double-blind randomized control trial in 167 children, and it dropped the risk of influenza A or asthma by 42% if they took 1,200 IUs of vitamin D per day. Annals of Internal Medicine in 2012, there was a decrease in COPD exacerbations by 43% versus placebo if the serum level was less than 10. So again, this points out the fact that we've just discussed, that deficiency is where you're going to have your best effect, not only for respiratory infections, but for everything, really. Now, this is something that I know at least for myself, when I was trained in medicine, we were all taught to use if we're repleting deficiency, use 50,000 IUs of ergocalciferol. That's what I was taught to do. I know that's what I see pretty much all the time, every week in patients. And in internal medicine, that's what we do. I want to point out this study, and I think it's really important, from the Journal of Clinical Endocrinology and Metabolism of 2004, is that D3 is much more effective than D2. So cholecalciferol is more effective than D2. So basically in this study, what they found is that when they repleted levels with D2, which is ergocalciferol, it's actually a synthetic made from yeast, versus cholecalciferol, which is what's usually biologically found in our bodies, D2 is 1/3 less potent, and basically when they would give D2, the levels would fall back to baseline after a number of months, versus D3 would stay in the system. So if we're repleting a deficiency, I would highly recommend using D3 rather than D2. And I myself, when I'm trying to replete it and use D3, I actually use right now a compounding pharmacy to do the 50,000 IUs of D3 instead of D2. You may be able to do that just by having people taking it from over the counter. You can get a 10,000 IU pill and have them do 5 of those. What I have found, and this is my clinical experience, is sometimes when they're doing those five 10,000 IU pills over the counter, they don't work as well, and I don't know why. So I'm just sharing that. That may not be, that's an N-of-1 experience, I get that, so you may need to check that out for yourself. But that would be another potential option. So The US RDA for adults is 600 to 800 IUs per day. Some studies suggest 10,000 IUs per day. Now they've started to change how they label dosing. So I just put the conversions there. If you're trying to do it in micrograms, it's 25 micrograms for 1,000. And I put the conversion there for you. And then we all know that it's best to check 25 hydroxy vitamin D levels when we're checking vitamin D because it's more stable. Above 100 nanograms per milliliter, and I've seen this in a number of patients, there's an increase in hypercalcemia. You can get calcification of the tissues. And I also want to point out, and I try to remind patients, more is not necessarily better. And you can get actually atrial fibrillation and other issues if the vitamin D is too high as well. So really, doing it in a balanced way is helpful. Okay. So the bottom line for Echinacea and vitamin D, Echinacea, the studies are very mixed quality. There may be some benefit potentially for prevention and maybe for acute treatment, but it's really hard to know. For vitamin D, really, if you're deficient, you'll have an increased risk potentially for respiratory infections. Regular dosing, as I've mentioned, on a weekly or daily basis is going to be more effective than doing it once a month or once every 3 months. And I would highly recommend using vitamin D3. It's more effective based on the study I shared. Something I like to add a little bit of something new because these are all the ones I've gotten a lot of questions about, which I'm sure you've even gotten questions about. And yeast, Brewer's yeast is actually a supplement that you can actually buy like in a container over the counter in a health food store. And it's basically like a food. And there is this study, interesting study from 2010, just to add some variety to the supplements we think about, which was a double-blind randomized controlled trial of 112 patients with no recent influenza vaccine who received Brewer's yeast versus placebo for 12 weeks. And it dropped the incidence of URIs or influenza by 10 to 20% over 12 weeks. There was no change in the severity of symptoms once they dropped it, but it did drop the incidence. And why I say this is because it's very well tolerated. It's actually a food, unless you're on a Mayo inhibitor, which very few patients are these days. It's also high in B vitamins and other nutritional value for thinking about. These are questions. Now I'm going to add some questions that I got from patients in the past few weeks I really want to emphasize to avoid using colloidal silver. Colloidal silver is a liquid solution of silver particles, and colloidal silver actually has been associated with a number of problems, including something called blue man syndrome, where people turn actually a grayish color of their skin, and you can actually develop leukemia from using colloidal silver over long term. There's actually reports of that. So I really highly recommend avoiding colloidal silver. There's also this product called Miracle Mineral Solution, which I know some people were using. This is actually a 28% sodium chloride with water solution, and that's basically drinking bleach. So, we don't want to drink straight bleach. That's not good for our health. It's, kind of makes sense, right? And so then that obviously could then cause problems like nausea, vomiting, diarrhea, and actually cause death. So I'm not saying that, anyway, I would just highly recommend avoiding products like this. And then I'm adding these two because I got questions this past week on these two products. Vitamin A is another question I got. And vitamin A, actually, there's no data to support that it decreases respiratory infections in children. I listed the study there. There's no decrease in the severity or incidence of pneumonia. And they actually did a really nice study. The World Health Organization is very interested in this, because obviously there's vitamin A deficiency from a world perspective. And they did a really large-scale, not even multi-center, but multi-country study on this. And they didn't see any difference in the severity or incidence of pneumonia, which doesn't mean that vitamin A deficiency doesn't have other problems. Also remember that vitamin A, and I ran into this week, is, if you do too much of it, especially in preformed, retinol, it actually can cause liver injury. So you really would want to avoid that. Copper. I had a patient this week who was using 20 milligrams of copper per day as a treatment for trying to prevent COVID. There's really no data to support that for respiratory illness. And remember that the upper limit is 10 milligrams per day. Above that, you actually run into the risk of liver damage. So I would not recommend using copper. Okay, and here I've listed all the references: vitamin C, zinc, probiotics, elderberry, echinacea, vitamin D, vitamin A, everything that you would hopefully need to know for information on supplements. Thank you. Yes?
I have two questions. I'll do them one at a time. The first question is the data you presented on the elderly with a fairly significant degree of certain deficiencies. So should we be recommending a multivitamin that has those things in them for all of our elderly? And if so, which brand or which type should we be looking for? That's question number one.
So let me repeat that question. So the question is, there was some significant data that was presented on, or that I presented regarding the study of patients who were elderly in nursing homes who had very significant vitamin deficiencies, as we discussed, folic acid, et cetera, zinc, and whether it would benefit those patients to use a multivitamin, and if so, what brand. So actually, that brings up a great question, because as we know, the data on multivitamins has been very controversial in general in the general population. What I like to, this is a brief addition to that, which is that the standard American diet in general is extremely poor. And this is not a time to go through all of the ways in which there's deficiencies in that diet. But we need to remember that the first step to treating any vitamin deficiency is obviously to look at the diet and try to help patients with that. That being said, in the elderly, there's a lot often mechanical issues. Maybe somebody's had a stroke, they have dysphagia, they can't swallow, they have limitations, and so then we really can't have the same impact on diet that we would hopefully want to. And then there's also taste. A lot of them lose their sense of taste, which actually is associated with zinc deficiency. So if they were going to do a multi, I generally recommend a basic multi, once a day. A good brand that I often myself recommend is Thorne. So I'll spell that for you. It's T as in Tom, H as in Harry, O as in octopus, R as in Roger, N as in Nancy, E as in egg. And they have a basic multivitamin that's just 2 a day. But if you had an elderly patient and they even just did 1 a day, that would probably address all of those, or I shouldn't say address all of them, but it would support them. Why that brand is because they do independent testing on their products, and also they in Consumer Lab have gotten on other things positive evaluation. Does that answer your question? Yeah.
And then so rather than testing all those elderly for vitamin deficiencies, which is expensive, the second question is about the lactobacillus bifidobacterium. Because you mentioned certain brands of that, but what about just eating an activated yogurt? Would that give everybody enough if you did that every day, rather than taking a supplement?
That's a great question. Thank you for asking that. And I'm very grateful you asked that question. So the question is, what about, instead of taking a probiotic pill, why not just do a yogurt or another fermented product? Would that be equivalent? That's a really good question. So if we look at probiotic content of yogurt, what they actually do when they make yogurts, they make the yogurt, which is a fermented food, so we'll have healthy, let's call them yogurt bacteria in there. And then they add the probiotic to that. So let's say it's lactobacillus they're adding in, they just stick it in there, or bifidobacteria. Remember that even though they've just stuck it in there, now they put it on the shelf. As it sits on the shelf, the probiotics, the lactobacillus and the bifidobacteria they lose viability very quickly on the shelf because they're really actually outcompeted, let's call it, by the yogurt bacteria, which is their native ground, right? And so it's a little bit harder for the probiotics to like muscle up, let's call it, to those other bacteria. So what they've shown is that those numbers drop. So if we're trying to use something for a medical reason, it sort of depends, right? If we're using, because eating fermented foods, there's lots of benefits to regardless, and for general health, it's very powerful. And if we're trying to use it for like a reason, ulcerative colitis or something, or respiratory infections, I would probably still recommend the probiotic capsule, let's call it, especially in a standardized amount, or like a standardized milk or something like that, because the Shirota brand is actually a standardized milk, because then it's been specifically designed to, let's say, compete. Does that answer your question?
So is there any food that would have equivalent that doesn't degrade?
So ones that are higher than yogurt, kefir, Kefir, is higher in probiotics than, let's say, a yogurt. And then if people have, let's say, sensitivity to dairy or things like that, then sometimes I'll recommend kimchi or fermented vegetables, sauerkraut, things like that. Yes,
Thank you,
ma'am.
Dr. Pujari. I do have a few questions
Yes.
from the audience. Thank you. The first one is, I have read that vitamin D is better absorbed with K2. Do you know anything about that?
Yeah, they're both fat-soluble vitamins. I've looked at the data on that, and I'm not fully convinced that it's better absorbed with K2, although I do see a lot of patients talking about that. Vitamin K2 has actually then got a bunch of subsets. You know, there's MK7, there's different forms of K2. And the theory I had looked into also was that vitamin K2 subset K4 actually would decrease the increased calcification of arteries that might happen with increase. But the data to me is still a little bit light. So the answer is really at this time, I cannot comment on that because I think the data is still unclear.
Okay, thank you. And another question is, what about selenium?
Yes, for respiratory infections or in general?
It wasn't specified.
Okay. Selenium has a very thin toxic to therapeutic ratio. So first we have to remember that. Selenium, if it's deficient, it can be a problem. But if it's above 200 micrograms per day, it's also a problem. And that's something people have to keep in mind because, again, I see patients using way too much selenium. Selenium's more looked at, generally speaking, for anti-cancer as an antioxidant, a trace mineral that way, less data on respiratory infections.
Thank you. And we have a question. It was mentioned not to use certain supplements in patients with autoimmune disease. Is this if they are on immune supplements or
Immune suppression?
Suppressants, thank you, or regardless of treatment of the autoimmune condition?
It's a theoretical risk, and again, this is a very long discussion because the problem is, again, when people say it boosts the immune system is a very, very complex system, and it's in balance. So actually it's better, for example, to often use the word immune modulation because, say, probiotic, it'll actually support the immune system, but it'll also decrease the immune system in autoimmune disease. So it depends. And so the issue that I mentioned with Echinacea is it's actually a theoretical risk that was proposed, but there's not really a double-blind randomized control trial saying this is actually an issue. And the answer would be, from a common sense standpoint, I would say I'd probably avoid it if somebody's on immune suppressant.
Okay, thank you. And just one more quickly. Do you recommend to have a vitamin D screening test for patients in general?
In general, that So they actually did a study on that, I believe here in Seattle, and said that it's so likely to be low in vitamin D that you should just make sure people are taking vitamin D rather than testing. Because now, what I will say though, I do test for vitamin D. Why do I test? I see a select population where people are doing a lot or little, or they'll have like, I can just go through, a malabsorptive syndrome or something like that, where really I don't know how much they're getting or whether they have fat-soluble vitamin deficiency. And so then it's with a targeted reason. But generally speaking, at least in this area, it's sort of like practically everybody should really just be making sure they take vitamin D.
Thank you very much. And just from the audience, thank you. This was excellent.
Oh, thank you so
Appreciate
much.